One and all, very good evening to all doctors who have joined into this link, uh, and very good evening to all the seniors too, and uh, be it the junior cardiologists or the seniors who are gurus in the field. Uh, we have gathered here with the intent of aiding education and ultimately getting our aspiring doctors to meet with the brightest of minds who can help them in their medical education and ultimately further patient care. So without wasting much time, let us start off with the Cardio PG Masterclass that we have intended. I have the honor of introducing the esteemed faculty for the day. So welcome all to Macleods Cardio PG Masterclass by the Procare-CV division of Macleods Pharmaceuticals. We have as our esteemed course directors none other than Professor Ajay Mahajan, Professor Dr. Ajay Mahajan sir, and Professor Dr. Kamal Sharma, who require no introduction in the field of medicine or cardiology, as you all know. But nevertheless, I have the honors to do the furthers. So today, the focus would be a presentation on valvular heart disease by Dr. Devrat, which would be in the second half of the session. As at the first, we would start with a keynote presentation by Dr. Bansal sir, Dr. Manish Bansal sir, on the role of echocardiogram in valvular heart disease. We also have as our expert panelist for the day, Dr. Ajay Bal, who would contribute further. Just a take home on the esteemed faculty who are involved with the meeting throughout the entire course. Very quickly coming to the introduction of the faculty, we have Dr. Ajay Mahajan, who is Senior Consultant and Interventional Cardiologist, and also the Head of the Department of Cardiology at KEM Mumbai. We also have Dr. Kamal Sharma, who is a Senior Cardiologist from the the reputed UN Mehta Institute of Cardiology at Ahmedabad. We have Dr. Manish Bansal, who is Senior Director, Clinical and Preventive Cardiology at Medanta, Gurgaon. Finally, we have Professor Dr. Ramakrishnan, who is Professor of Cardiology at AIIMS New Delhi. So with the best of the faculty who can hone the upcoming minds, I now take the pleasure of handing over the session to Professor Mahajan sir. Mahajan sir, over to you.
Good evening, everyone. So, to all the students, and sincere thanks to Mr. Manu Agarwal and to collect this galaxy of faculty and the who's who in the subject is the most challenging thing which he had done. Professor Kamal Sharma is the cardiologist which everybody want to be like him for his memory and remembering the things. And today's my two moderators, Professor Dr. Rama and Professor Dr. Manish Bansal. So Manish Bansal sir is the world authority as far as the
I think Dr. Mahajan.
I think we lost Dr. Mahajan. So let me complete the introduction of Dr. Bansal. I've known him as the world authority in echocardiography, in writing papers, that I've had a brief stint with him in collaborating whenever we were doing a couple of research papers, including his wonderful short stint as the editor-in-chief of Indian Heart Journal as well. So over to Dr. Bansal, and he's the best guy to learn echocardiographic assessment of multivalvular heart disease. And I thought when I was deciding what faculty to choose, I think no other name came to my mind when it was echocardiography or multivalvular than Dr. Bansal. And I'm very much thankful for him to accepting this honor and enlightening all of us and as to how to approach a multivalvular from the perspective of a DMPG residence. Over to Dr. Bansal. Thank you very much.
Thank you so much for this opportunity and for very, very kind words. I don't think I deserve those accolades, but I'll try to do my job to the best of the ability. Now, it is certainly a pleasure to talk about this very important topic. Let me just share my slides. So multivalvular disease is something which we very commonly encounter during day-to-day echocardiography practice, and it always presents diagnostic dilemma. And when we see the patients as clinician, it presents with therapeutic dilemma as well. I'll just begin with a case example here. So this is an 88 years old gentleman who had diabetes, and he was having features of congestive heart failure. He underwent echocardiogram. So as we can see here, his aortic valve is thickened and hardly opening. He also has extensive mitral valve calcification, and mitral valve also appears to be significantly diseased. Here we have on the right hand side gradient across the aortic valve. It is a parabolic shaped trace suggestive of significant aortic stenosis, but mean gradient was 25 only, max gradient 40. Now in this setting, we know that this would still indicate significant AS because the valve opening is markedly reduced. So what we are dealing with here is low gradient severe aortic stenosis. But at the same time, as I mentioned, he's got significant mitral valve disease also. The gradient across the mitral valve was 7 millimeters of mercury, mean gradient is 16 max gradient. So he had significant mitral stenosis and he had mitral regurgitation also. So now, first issue that arises is about the diagnostic dilemma. And here, as I mentioned in the previous slide, even though the gradient was low, we knew that he had severe AS, and that is known as low gradient severe AS. But the bigger issue is that how to deal with this patient. The cardiologist who was treating him was keen to do TAVR. But in such a patient, TAVR is unlikely to benefit the patient because it will only take care of LV outflow obstruction, but the mitral stenosis would not be relieved, and his symptoms are likely to be more because of this extensive mitral annular calcification and MR and less from aortic stenosis. So this kind of combination keeps arising every day. Now, as I mentioned, multivalvular disease is very common. We have got many studies to show that. This is data from the REMEDY study, which was conducted across 12 African countries, plus India and Yemen, including 25 hospitals, and data of more than 3,300 participants. Now, in these countries, we know rheumatic heart disease is common, and therefore, here this data was entirely on rheumatic heart disease patients. And in rheumatic heart disease, multivalvular disease is very, very common, and that is what was reflected in this study also. 64% of the patients had moderate to severe multivalvular disease, all these green components in these bars. Other studies from Western countries have also shown a good prevalence of multivalvular disease, though not so much common as we see in India. So how does it affect our echocardiographic assessment and patient management? So the first issue that comes up is regarding the diagnostic assessment. And the reason why it arises is that the hemodynamic impact of the two valve lesions, 2 or 3 or 4 valve lesions sometimes, which are present, the net hemodynamic impact of the valve lesions depends on a number of factors. Which valve lesions are present, I mean, which valves and what lesion, whether regurgitation or stenosis, what is the etiology of those lesions, what is the severity of each valve lesion, what is the duration of those valve lesions, loading conditions like blood pressure and preload, and the ventricular response to those valve lesions. All these factors determine the net hemodynamic impact of the valve lesions, and that is what will determine the diagnostic information that we derive from various tests. So the basic dictum here is that anatomic assessment is more reliable than Doppler assessment. I will be talking about this in subsequent slides. So we are going to rely more on anatomic parameters here rather than on Doppler-based parameters. The second is therapeutic dilemma. So when a patient has 2 or more significant valve lesions, Then while deciding about the appropriate treatment, we need to look at the overall hemodynamic effect of each valve lesion. Then we need to figure out whether the valve lesions need surgical treatment or is there a percutaneous treatment option available. What will be the impact of adding another surgery, doing double valve surgery rather than single valve surgery? What would be the added complication risk because of giving two prosthetic valves? What if we don't do surgery, the second valve surgery now and leave it? How will it impact the future natural history, and what will be the reoperation risk? All those things need to be taken into consideration before we reach a conclusion about how we are going to manage this patient. So regarding treatment, the broad guidelines are that if there are two or more severe lesions, then we need to tackle both the lesions together. It may be surgical treatment or maybe percutaneous or maybe a hybrid procedure, that one valve is treated surgically and the other one is treated by transcatheter means. If one valve is severe and the other one is non-severe, then the treatment approach is decided mainly by the lesion which is more severe, and the other lesion is treated on case-by-case basis. If there are two or more non-severe lesions, then we have to individualize the treatment decision. So let us look at some valve combinations which we see commonly. First is the combination of aortic stenosis and mitral regurgitation. This is one of the very common combinations. It can occur either because of degenerative disease. As I showed you in the beginning, there is calcification of both aortic and mitral valve leaflets. It's very common in the Western country in elderly population. It can also occur because of rheumatic heart disease, or it may be due to functional reason. That is, the aortic stenosis is severe. It leads to LV systolic dysfunction and dilatation, which causes AR. It has been shown that it has been shown that in patients who are undergoing aortic valve replacement, some degree of MR is present in 60 to 90% cases, and moderate or more severe MR is present in 13 to 74% patients. Now, when these two valve lesions coexist, assessment of aortic stenosis becomes challenging because gradient will be falsely low. So we will see more of low flow, low gradient AS. Here for this reason, rather than looking at the gradient, we need to look at aortic valve area, which we can derive using continuity equation. We may have to look at contractile reserve. And if it is not conclusive, then CT to assess the aortic valve calcification will be helpful in deciding about the severity. On the other hand, significant aortic stenosis increases the severity of MR, particularly the amount of blood which is regurgitating. So valve orifice, regurgitant orifice may not change, but the volume of the blood which is leaking will increase. And therefore, the jet area will not be reliable. We will have to rely more on ERO. And here is one example. So this patient had AS and MR. This is pre-operative image. As we can see here, ERO was 0.27 centimeters square, regurgitant volume 41 ml. This patient underwent AVR, and after that ERO is same, but the regurgitant volume has come down. So this occurs because in the presence of AS, LV systolic pressure is elevated, and that causes more blood to regurgitate through the mitral valve. Now, when only aortic valve is dealt with, some patients may have reduction in MR. In many patients, MR may persist. What are the factors that determine who will have residual MR? So if there is significant LA dilatation before aortic valve intervention, if MR occurs despite aortic valve gradient not being too high, and if there is atrial fibrillation, then there are more chances that the patient will have residual MR. When there is any amount of residual MR associated with two or more of these risk factors, it is associated with worse outcome also. There is increased risk of heart failure and overall mortality. MR is common in patients undergoing TAVR also. Here, degenerative MR is more common because TAVR is usually performed in elderly population, and it has been shown that if there is significant amount of degenerative MR persisting after aortic valve intervention, the mortality is increased. Whether we look at 1 year follow-up, all-cause mortality, or 2 year follow-up, all-cause mortality, increase. So these are the things that we need to keep in mind when we are deciding about intervention for these patients. Now, the second combination that I want to talk about is AS and MS. Now, this is a combination which is less commonly encountered in Western world because their degenerative AS is very common, but degenerative MS is usually not severe. So mostly it is mild to moderate MS. But here in India, we see this quite commonly because of rheumatic heart disease. Now, in these patients, if we only treat mitral stenosis, it can prove quite detrimental because there will be sudden increase in the LV volume, which may create problems. How will this affect the assessment of the valve lesions? Once again, in case of aortic stenosis, gradient may be falsely low, so we will see more of low flow, low gradient AS, and again we have to rely on continuity equation for aortic valve area and CT for aortic valve calcification for assessing true severity of AS. In case of MS, pressure half time will become unreliable because there is increased LV, there is LV hypertrophy, so LV compliance is reduced, so pressure half time will not give us the accurate assessment of mitral stenosis severity. We may also see low flow, low gradient MS because LV EDP is high, so the transmitral gradient may be lower than the actual MS severity. So again, we have to rely on anatomic assessment, that is direct planimetry of mitral valve area. Another combination is AR and MR. It can occur in two distinct scenarios. One is that the patient has severe MR because of which LV dilatation occurs, and then that leads to secondary MR. The other possibility is that the both valves have organic involvement. It may occur in rheumatic heart disease, it may occur in myxomatous disease or connective tissue disease. Now, unfortunately, this combination is very poorly tolerated by the ventricles because there is double volume overload. So in these patients, there is more marked LV dilatation and dysfunction. Pulmonary hypertension is more common, and there is greater likelihood of post-operative LV systolic dysfunction. So here, the challenges in echocardiographic assessment would be that for AR, volumetric methods will be challenging because for volumetric assessment, we need to calculate stroke volume at two valves. Usually we do it at aortic and mitral valves. So here in the presence of MR, that will not be reliable or applicable. Then pressure half time method may not be reliable because MR will result in rapid increase in LVETP. Vena contracta is something that we will have to rely more on. Similarly, for mitral regurgitation assessment, volumetric methods will be challenging. We will have to use PISA, and even for assessment of aortic of LV systolic function, LVEF may not be that reliable, and we may have to resort to using global longitudinal strain. Now, AR and MS is a combination which we see very commonly because of rheumatic heart disease. In rheumatic heart disease, we know that nearly 1/3 of the patients have 1/3 of the patients who have MS have aortic valve involvement also, and often it is AR. So here, MS can blunt the increase in pulse pressure, and therefore it may mask the signs of aortic regurgitation. So clinical assessment will become challenging, and even the echocardiographic assessment will also become challenging. Pressure half time, again, not reliable. We will have to rely on vena contracta. For MS, pressure half time will not be reliable because AR is there, so that will affect the LV afterload and the LV pressure. AR jet may create problems in measuring mitral valve gradient because both merge into the LV cavity, and getting proper Doppler trace becomes challenging. Continuity equation will not be reliable, so we will have to rely on direct planimetry. Lastly, the combination that actually is the commonest and has been a major source of trouble for us who've been treating patients with rheumatic heart disease for many years. By us, I mean clinicians in India, and that is the combination of mitral valve disease with TS and TR. See, many patients who have got mitral stenosis, severe mitral stenosis, who develop pulmonary hypertension have significant tricuspid regurgitation. Now, when there is severe tricuspid regurgitation, it usually does not affect assessment of MS severity unless there is right heart failure and reduced cardiac output. On the other hand, assessment of TR severity is challenging because it is very much load dependent. If we diurese the patient, TR may decrease. If the patient is congested, TR may increase all of a sudden. So this dynamic nature of TR needs to be taken into consideration. Now, over the years, it has been a common belief that once we treat the mitral valve disease, it will take care of TR also if it is secondary TR. However, numerous studies have shown that this does not happen. And because of this, now we are facing many patients who have undergone mitral valve surgery many years ago, and now they are coming back with severe TR. And in that setting, we hardly have any treatment option for those patients because they have advanced RV systolic dysfunction also. So I will go back to this old study here. This included 32 patients who had moderate to severe TR and were undergoing BMV. 20 patients had successful BMV. In 12, balloon mitral valvotomy was not successful. So in those who had successful BMV, TR did not change in 13, it decreased in 4 and increased in 3. Those who did not have successful BMV, TR did not change in 10 and increase in 2. So out of 32 patients, TR decreased in only 4 patients after a follow of 1.5 years. And it increased in 5 patients and remained unchanged in 23 patients. So, and there are many other studies which have shown that TR usually does not decrease and may even increase. And this occurs because once there is tricuspid annular remodeling because of constant RV pressure overload, then tricuspid annulus becomes dilated and that TR does not decrease. Leaving TR untreated leads to bad outcome. There are numerous studies to show that. This is one study here, chronic MR patients and 311 undergoing mitral valve repair. In them, if the tricuspid annular diameter was more than 70 millimeter, tricuspid valve repair was performed at the same time as mitral valve repair. So nearly half underwent combined procedure and half underwent only mitral valve repair. So as we can see here, after 10 years, even though the patients had undergone combined procedure, which would have increased surgical mortality to some extent, the 10-year outcome was better in those who underwent combined procedure rather than those who underwent only mitral valve repair. And here we have a more recent data from Partner 2 study, that is a study which looked at patients undergoing TAVR, more than 500 patients. And as we can see here, those who had severe TR pre-procedure, in them, 1 year mortality rate was 61% as compared to those who had only mild TR and had much less mortality. So this shows the impact of TR on long-term outcome. Many people fear that if we perform tricuspid valve surgery, it will be associated with significantly worse outcome, but that is not entirely true. And here we have this large data of 328 patients who underwent tricuspid valve surgery for rheumatic heart disease. This is a consecutive series published in 2008. So in this, most patients had predominantly TR and for which they underwent surgery. Tricuspid replacement was performed in 31 and majority underwent tricuspid valve repair. In hospital operative mortality was 7.6%, which was not too high. The patients were followed up for 8.7 years. So what was found was that when the patients underwent isolated tricuspid valve surgery, the mortality was very high. The reason was that these were the patients who had significant tricuspid valve disease, and it was so severe that the patients were taken up for surgery despite only tricuspid valve being affected, and that is the reason why the mortality was high. But in patients who were undergoing multivalvular surgery, the mortality was not that high. Secondly, first surgery was associated with much lower mortality as compared to reoperation, and valve repair was associated with much lower mortality as compared to replacement. So this data shows that if a patient is undergoing mitral valve surgery and has significant TR, treating that TR at the same time as mitral valve surgery can be done with acceptable mortality risk, especially if we are doing well repair. If we leave that TR and operate the patient later, then the mortality is going to be several times higher. And for this reason, all the guidelines recommend more aggressive approach for treating tricuspid regurgitation in patients who are undergoing mitral valve surgery. So here we have recommendations from European Society of Cardiology. If there is severe primary or secondary TR, this is an indication for tricuspid valve repair. But even if there is mild TR and tricuspid annulus is dilated, then that is also an indication for tricuspid valve repair. So any patient who has got severe TR or dilated tricuspid annulus should undergo tricuspid valve repair at the time of mitral valve surgery. So then the next question arises is, what is the definition of tricuspid annular dilatation? So the currently accepted definition is based on this paper, which was published by Dr. Naveen Nanda and Dr. Chopra many years back. And in this study, they showed that when the tricuspid annulus diameter was more than 21 millimeter per meter square, it was associated with severe TR. So the current guidelines also recommend the same threshold. And if we look at our patient's body surface area, so anything around 35 millimeter or more should indicate dilated tricuspid valve annulus. So lastly, here I have these tables which summarize whatever we have discussed regarding the hemodynamic effect of the combination of various valve lesions. I will not go into those details. So just to summarize, multivalvular disease is common, especially in our region with high prevalence of rheumatic heart disease. The overall hemodynamic impact and the net clinical picture are quite variable. Assessment of severity of individual lesions often quite challenging. Anatomic parameters are better than Doppler parameters. The combination of valve lesions often presents major therapeutic challenges. Both under treatment and over treatment of the second lesion is quite problematic, and therefore we need to have very careful decision making. Thank you so much.
Thank you, Professor Bansal. Actually, this is the most important lecture because Sir had already given a most importance is anatomic evaluation of the valvular disease, because sometimes when there is a multivalvular disease, Doppler estimation might be misleading, and we have to judge the cases on anatomic assessment. And another important thing is giving importance to the tricuspid regurgitation. Most of the time, we always thought that this is a secondary tricuspid regurgitation, and after treating primary lesion, we might get a significant reduction in that. But if there is a annular dilatation of the RV, then the chances of getting reduction of tricuspid regurgitation is less. So at the time of index surgery, we have to take into consideration regarding the intervention in that particular scenario. So now, if Dr. Devavrata is ready, then we can start with the long case presentation with the multivalvular disease. Dr. Devavrata.
Yes, good evening, everyone. So, extremely sorry about the delay of the network. So there was a network issue. So.
Can you share the presentation, Dr. David?
Yeah, yes, I'll share. So.
So Dr. Devdutt will be presenting a case of multivalvular heart disease, and his clinical assessment will be done by Professor Dr. Ramakrishna, who's a very good friend of mine and a very senior and a very highly influential academic person from AIMS, Delhi. Also with him, Dr. Bansal, who's already taken the case, and Dr. Marjan will be helping me as they're completing the 4 panels of examiner, which is what we are trying to mimic is usually the standard practice of examination across country. Dr. Devdutt,
Sir, can you screen my? Sir, can you see my screen, sir?
No, sir.
No.
Just first of all, open your presentation.
So I'll open my presentation.
Just make it in presentation mode, sir.
Okay, sir. Sir, am I audible, sir?
Yes, sir. Perfectly. Just make it your presentation in slideshow mode.
Okay, sir.
Make it full screen.
Okay, sir.
Not yet.
No problem. You can start presenting it. Even this is okay. We can see your slides. Please go ahead with the next slide.
Okay, sir. Okay, sir. Good evening, everyone. I'm gonna present. I'm Dr. Devraj Singh from UN Mehta Hospital of Ahmedabad, sir. History, sir. I am presenting a case of 25-year-old male resident of Bhuj, Gujarat, working as a
Please change your
housekeeping super.
slides.
Sir?
Just click on the screen and try to change slide.
Yes. Sir, I am presenting a case of 25-year-old male, sir, resident of Bhuj, Gujarat, sir, working as a housekeeping supervisor. He's coming from lower middle socio-economic class, sir. Came to UN Mehta Hospital with the chief complaints of breathlessness on existence since 1 year and palpitation since 1 week, sir. So these are the chief complaints, sir. History of presenting illness, sir.
Your slides are not moving, Devrat. Can you?
So it's not moving, sir.
Just click on the screen, sir. Yes.
Yeah, now it's moving. Yeah, going. Go on.
Okay. So history, sir, can you see, sir?
Okay, fine. Next, yeah, history of present illness.
Yes, sir. History of presenting illness. Patient was relatively asymptomatic, sir, before 1 year when he started having symptoms of breathlessness, which was insidious in onset, sir. Initially, patient had a symptoms during walking to his workplace, which is around 2 kilometers away from his home, sir, or climbing around 2 flights of stairs, suggestive of NYHA class 2, sir, which gradually progressed to walking for approx around 100 to 200 meters or climbing 1 flight of stairs, suggestive of NYHA class 3. Breathlessness was relieved by rest and was not associated with any cough, expectoration, or seasonal variations. Since last week, patient had breathlessness even at rest, associated with orthopnea, and patient had also 1 episode of PND. Patient had also developed palpitations since last 1 week, which was irregular, sir, sudden onset even at rest, and relieved spontaneously, and no relation to any activity, sir. There is no history of any chest pain, no history of any hoarseness of voice or dysphagia, no history of any hemoptysis, no history of any pre-syncope or syncope, no history of any prolonged fever, joint pain or skin lesion, no history of any edema of feet, abdominal distension, nausea, vomiting, no history of any recurrent LRT in the childhood or bluish discoloration or cyanotic spells. After hospitalization, patient was initiated with some IV medication that has led to increase in the urine output and relief in the symptoms.
Devrata, just I want to interrupt you.
Yes, sir.
So now your patient is 25 years old.
Yes, sir.
Symptoms started just 1 year.
Yes, sir.
Within 1 year, he became from NYHA class 2 to class 3.
Yes, sir.
So what is your interpretation from this history?
So young male patients presented with no history of any rheumatic fever, progressive breathlessness from NYHA class 2 to 3. First thing I'll try to think it as a dilated cardiomyopathy with severe LV dysfunction, post-myocarditis, and presenting with a failure.
Okay, only second.
Next, sir, I can think about is a valvular heart disease, likely likely from the LV stenotic lesion, sir, and that is precipitated by some precipitating factors such as arrhythmia or any of the precipitating factor that has led to LV failure.
LV stenotic lesions means?
Sir, mitral stenosis.
LV inflow obstruction.
Inflow outflow obstruction. Sir.
Inflow and outflow both or only inflow?
Sir, inflow obstruction. Sir.
Inflow obstruction. Okay. Then?
Sir, one of the differential I'll try to keep it here is even RSOV, sir. Young male had presented without, but only thing that goes against is the patient did not have any precipitating factor that like sudden onset of chest pain, but yeah, progressive breathlessness, palpitation since 1 year. One of the RSOV can be one of the differentials.
So, Devrat, which one will you keep first, like DCM or RST in this case?
So I'll keep it as a DCM, sir.
So how many DCMs you have seen who present with AF for 25 years of age? Because you are categorical about atrial fibrillation because the patient had irregular heart rate, which was episodic. So how common is atrial fibrillation in 25-year-old with DCM?
So AF is less likely, sir. But actually, from here, why I was thinking, because there was a progressive breathlessness, very short duration
But
patient.
if you are very categorical about AF, these are the 2 points that you have. Like one is a arrhythmic type of palpitation, which is irregular. You are committed to irregular palpitation, which has precipitated class 4 heart failure. So
Yes.
this has to be some rheumatic heart disease unless proved otherwise.
Yes, sir.
In a
Yes.
25-year-old in India.
Yes, sir.
So that because if it is not AF, then I would agree. Like possibly you can keep your DCM as a possibility.
Yes.
So, but if it is rheumatic heart disease, which lesion now?
So LV inflow obstruction, sir. AF has precipitated the
Single valve AF or single valve disease or multivalvular disease?
Likely is a multivalvular heart disease.
How do you make out from the history that it's likely to be multivalvular?
Sir, is one that patient is having progressive breathlessness and palpitations are there, sir.
No, but what are the type of palpitation? You are committed towards arrhythmic type of palpitation.
Arrhythmogenic.
Are there any other associated type of palpitation like a volume overload type to suggest that there could be additional lesions?
No, sir. There is no any additional patient does not have
So,
any.
what is the probability of somebody coming to 27 years having isolated MS versus MS with what else is commonly found? Like MS with
MS
what?
with MR is most common, so that.
Or MS with AR. So, what is the likelihood?
So MS with MR is 46%, while MS with AR is 26%, sir.
That is in all patients who have multivalvular heart disease. But if a patient comes to you with MS in 27 years, so what are the chances that it is going to be only isolated MS?
70-75%.
So go on, summarize your past history and others, complete the
So
history
you have
part,
to
and then we can have
consider
some
one possibility. If there is a pre-existing valvular heart disease, and if there is a, on top of that, if there is a carditis, rheumatic carditis, then also you might get a deterioration very fast.
Yes,
so
sir.
that possibility also you have to entertain in this particular.
Yes. Yes.
Okay. Go ahead.
Yes. So past history, sir. No history of TB. No history suggestive of rheumatic fever in childhood, sir. No history of hypertension, diabetes, or CKD. No history of any past hospitalization or major surgery, sir. Family history, sir. No history of any similar illness or cardiac disease in family. No history of any sudden cardiac death in family. Personal history, patient is vegetarian by diet, sir. Normal appetite, decreased sleep, sir. Non-alcoholic, and no other addictions. So to summarize, sir, 25-year-old male patient presented with the complaints of breathlessness on exertion since last 1 year, which was initially NYHA class 2, progressed to class 3 since last 1 month, also complaints of palpitation, which is arrhythmogenic type, since 1 week, associated with increased breathlessness, even at rest, so history of NYHA class 4, with no history of rheumatic fever.
So can this be atrial septal defect?
Sir, ASD, sir, less probable. Sir, it can be there if the ASD is associated with any PAPVC or
ASD associated mitral stenosis. It might be Lutembacious. It might be severe mitral valve prolapse with a flared mitral leaflet. It might be alpha.
What do you expect? Suppose if it is ASD with MS or ASD with MR, what do you expect like?
Sir, ASD with MS, sir.
If it is ASD with MS, that's what sir is suggesting. He's provoking you. So what is that? Like, suppose if it's ASD with MS or ASD with MR, can this be a possibility?
Sir, less likely because orthopnea PNDs will not be there because pressure will be transmitted towards the right side.
One is less likely. Orthopnea will be less likely. One more thing. What should be there? If it is an ASD MS or ASD MR, what should be there?
So RV failure patient will be having predominantly RV failure features.
So primarily a congestive heart failure will be there.
Yes, sir.
So what is against your possibility of an RSOV?
Sir, there was not any precipitating factor. Otherwise, the patient did not have any predominantly congestive cardiac.
How often you find that typical chest pain of RSOV in a patient with RSOV?
So at least So 40 to 50%.
So it's not in the majority. It's not majority. It's not found. So that cannot be used as a exclusion. So what else?
Sir, one
See, if the patient
patient
is
has
having
predominantly congestive cardiac failure features, sir.
So again, there also you expect right heart failure feature to be there if somebody becomes class 4 symptoms.
Yes, sir.
See, most of the
Also,
time, those RSOVs who are having pre-existing VSD with AR, and if they develop additional RSOV, they deteriorate very fast, and the history might be like this.
Yes,
So,
sir.
in that case, you might not get a chest pain, but a pre-existing history of congenital heart disease might be there in those cases.
Yes.
Yeah. And this insidious onset
And
of
more of there
symptoms
is
and
RV
progression.
dysfunction and severe pulmonary hypertension with orthopnea, PND, and progression of the dyspnea very fast.
Yes.
So why there is a more symptoms in RSOV?
Sir, because there is a high pressure is transmitted towards, because directly the aortic pressure is transmitted to the low pressure chamber. So the patient will having increase in the pulmonary blood flow, and that's the patient has the symptoms.
how is it different from a mitral stenosis, for example? You have on one extreme, you have mitral stenosis, and one extreme, you have RSOV. How is hemodynamically this is different?
Sir,
So mitral stenosis, what is the mechanism of heart failure or dyspnea?
sir, in mitral stenosis, predominantly patient will be having raised LA pressure, and that leads to the increased
So
pulmonary
basically,
venous.
pulmonary venous hypertension is the predominant hemodynamic mechanism. What
Yes.
about in this?
Here there'll be increase in the pulmonary blood flow. pH will be increased. So that's
this is one condition which is associated with both increase in pulmonary blood flow as well as pulmonary venous hypertension.
venous.
So how this increased pulmonary blood flow is different from other conditions like? So suppose you have a VSD and you have an RSOV to RV. For example, both of them are like from aorta to RV and a LV to RV. Both of them are shunting. How these two shunts are different? What is an obligatory shunt?
So that transmission that only occurs during the single phase of the cardiac cycle. That
No, what is an obligatory shunt? What do you
Obligatory.
understand by hemodynamic definition of obligatory shunt? So obligatory shunt is one which actually shunt. The quantum of shunting is not affected by your pulmonary vascular resistance. For example, whenever your pulmonary vascular resistance increases in VSD, the shunt starts to reverse or the shunt diminishes. Whereas in RSOV, this doesn't happen. So this is a kind of an obligatory shunt where, irrespective of your PVRI, your shunting will also happen.
Dr. Bansal, you were asking something.
No, I was just saying the same thing which actually Dr. Majan also mentioned, that insidious onset of symptoms, gradual progression will go against a diagnosis of RSOV, resulting in these symptoms.
so
So if the history was not of 1 year, how would that change? If this history was say 10 years, what would be more confirmed or what would be more ruled out? Same
mitral
history,
stenosis
10
will
years
be,
duration.
so MS will be more likely if there was a long history. LV inflow obstruction such as mitral stenosis will be.
Is it only by natural history or it's also because of some hemodynamics? What comes in between? Again, repetition of what Dr. Ramakrishnan was asking. What protects?
So, so the patient.
So in simplified terms, like how regurgitant lesions and stenotic lesion natural history differs. So
in
suppose
case of
somebody has MR,
regurgitation,
somebody has MS.
yes, sir. In regurgitation, there will be LA compliance, sir. And so it will try to, in case of the patient only becomes symptomatic if the patient develops LV dysfunction or when there is LV EDP, sir. While in case of stenotic lesion, there will be high LA pressure, sir.
Like simply for natural history, when think of like this, like if a patient of MR has a very long history of latent period
Yes,
before
sir.
they become symptomatic, but once they become symptomatic, there could be a decent deterioration may happen. But what about the MS? MS are generally symptomatic very early. Severe MS will be,
Yes, sir.
once they become symptomatic, they class 4 and all will happen like.
Yes. So,
So what about 10 years history of symptoms? What changes would you make? Suppose patient history is 10 years, now he has gone into class 4 symptoms.
so there will be long-standing pulmonary venous hypertension will lead to the interstitial fibrotic changes even in the lung, and that leads to the progressive. It's like that lead to persistence of the symptoms, sir.
And even in MS also, the way things were written in the West books, textbooks, and our experience may be slightly different. Like, so the natural history of MS in India and MS in the Western countries may be slightly different than what has been reported, like in the literature. You should read about the natural history of various valvular heart disease, like.
Yes.
Okay, move ahead, please.
Okay, sir. So my differential, sir. So first, I'll try to think of
Based on history, right?
Yes, sir. Based on the history, sir.
No,
My
but
first.
how did you never mentioned about hypertrophic cardiomyopathy and ASD with PH? Why are you even considering them? Like,
So it's very low side, but as the patient had two symptoms, sir. One was a dyspnea on exertion.
how many hypertrophic cardiomyopathy you have seen who have come with orthopnea and PND?
So orthopnea pain is less likely in an HCM, sir. It was just the dyspnea on exertion and that AF that was precipitated. That's why, sir, at very lower level, I have kept that hypertrophic cardiomyopathy. Sir.
What about your ASDPH? Why even think of ASDPH?
So if the patient is having any associated lesion with ASD such as PAPVC, patient, but
Why are you
patient.
repeatedly saying, is it different? Like, will
No,
a
sir.
patient with PAPVC behave differently to a patient without
No, sir.
PAPVC?
No, sir. It is very less likely, sir. Very.
So nothing is changed. Like, only the quantum of shunting may change.
Yes.
So
Sir.
that's all. Like, nothing is changed. Like, for example, sinus venous ASD almost always have a PAPVC, whereas first
Yes.
and second ASDs most of the time doesn't have. Most of
Rather,
you
you
cannot
should have
clinically differentiate
considered
or
all
natural
the
history
all the.
differentiate.
Rather, you should have considered all causes of mitral regurgitation in this case, or like a Alcapa or congenital mitral valve anomaly producing mitral regurgitation, or MVP with MR with a sudden flailing of the leaflet, and then you might get all these symptoms.
Okay.
So ASDPH is out. You cannot keep ASDPH like.
Okay, sir. Okay, sir.
Because why orthopnea or PND in that case? If
Sir,
you have a ASD with PH.
So they are less likely.
Even if you want to mention it, ASD will not be with PH.
Yes.
Once
Also,
PH develops, these things will not come into play.
and
Why, Dr. Ramakrishna asked you, do HOCM patients develop PND? They don't, you answered. Why? Why is it uncommon for the patients of HOCM to develop PND?
So PND, so basically it usually arises because of the vascular redistribution, sir. Like there are certain theories, sir, that one is a vascular
So what
redistribution.
happens during sleep, and that is what will happen in HOCM. So what happens to the heart rate in HOCM?
Sir, there will be sympathetic withdrawal, sir, and in the REM sleep there will be atrial tachyarrhythmias can be there, sir. But
No. That's not for the arm. So what is protective in
yes,
HOCM? Reduction in
yes, sir,
heart
sympathetic.
rate, right? Dehydration. So you don't take fluid, so EDP may come down. So these are again hypothesized mechanisms. You have to understand pathophysiology. If you have a diastolic dysfunction, primarily heart rate reduction is going to help you empty the LA, and the LA pressure is going to decrease. And hence, it's unlikely that during sleep your wedge pressures will increase. If the patient who's been asymptomatic on activity, in sleep it is fully likely to remain asymptomatic or actually improve on symptoms. So that's one of the hypotheses that in HOCM.
Okay, sir.
and also in recumbent position, LV outflow obstruction will also decrease,
Yes,
unlike
sir.
in the upright position. So that will
Yes,
also help HCM patient during sleep.
You will never
yes.
get PMD. True. So come to examination.
So general physical examination, sir. Patient is conscious, cooperative, well oriented to time, place, and person, sir. Height 178 centimeters, weight 53 kgs, BMI 16.7 kgs. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema, sir. Pulse is 66 beats per minute, sir. Irregularly irregular, sir. Pulses, different type of pulse is present, sir. Variable force and volume with bilateral symmetrical, no radial or radiofemoral delay, normal arterial wall tension, all peripheral pulse equally palpable, sir. BP, sir, in right upper limb is 102 by 50.
What is the apex pulse deficit?
Sir, actually, apex
That
pulse
you have to
deficit.
mention because the heart rate is only 60. See, in 60s only.
Sir, it is a
66 per
missed. Sir, it is a missed bit that we. It's like we basically compare from the. It's like we auscultate and what you feel in the peripheral pulse, sir. So out here, the pulse deficit was only 2, sir, because the patient was having AF with controlled ventricular rate. That's why I did not mention, sir. That. Ideally, in AF, the pulse deficit should be more than 10, sir, and VPC should be more than 6, sir.
Here, apex pulse deficit is only 2 beats per minute.
Yes, because as the patient is having bradycardia, sir. So.
Okay. So, what are the causes of bradycardia with atrial fibrillation?
So, if the patient is on beta blockers or calcium channel blockers, sir.
Or digoxin.
Or if the patient is on digoxin, so antiarrhythmic drugs, or if the patient is, so there are the conditions more likely so that the patient is on drugs.
Can such a patient have regular pulse instead of being irregular?
Yes, sir. If the patient is on digitalis, it can be, sir.
How?
If there is atrial fibrillation with the complete heart block, then what happens?
Sir?
If there is a AF with the complete heart block, then what happens to the pulse rate?
So it will. So it will.
Suppose flow rate, suppose
What
somebody
takes
is
over?
AF has flow rate, one of the possibilities is complete heart block.
Yes.
So can you clinically diagnose AF with complete heart block? What will be the rhythm in complete heart block if somebody has AF?
So it will become
regular.
What is the rhythm in complete heart
regular,
block?
sir.
You're right.
What is the
It will
rhythm
become
in
regular.
complete heart
It will
block?
become
So
regular
it will
because
become
ventricular
regular.
escape rhythm will come, so it will become regular.
Regular, yes.
The atrial beats are not getting conducted. So whenever you find a patient who has who was in AF now has a regular heart rate, you should think of complete heart block.
Yes.
Especially if
That
the
is the point
patient
I
is
was
on
making.
digoxin.
Yes.
Go on.
Oh.
So blood pressure, right upper limb is 102 by 58, left upper limb is 100 by 58, both lower limb is 140 by 50. Respiratory rate is 20 beats per minute, abdomen thoracic type, sir. JVP is pulsatile, sir. Upper level of column is about 8 centimeter above the sternal angle at 45-degree position. There is absent A wave, prominent CV wave with normal respiratory variation, sir.
So which type of manometer you use for measuring blood pressure?
Oscillometer, sir.
Oscillometrics. Is the oscillometric method good enough in atrial fibrillation?
So we can take a mean of 5 and
Now, how oscillometric methods measure blood pressure?
so it identifies the highest amount of that.
Does it oscillate like what we do, like Kotkov sounds?
No,
Or
sir.
how does an oscillometric method does it like?
It basically senses the highest amount of impulse that are that pulse wave that is transmitted to the peripheral pulse. So that is.
What is oscillometric about it? What is oscillometry? So
So
you
it
read
is,
about that's very interesting. So what happens in atrial fibrillation? It kind of measures the mean pressure and extrapolate the pressures like so. Is it reliable in atrial fibrillation?
so it is less reliable, sir. Manual.
No, how can it be less reliable? Atrial fibrillation is hypertension are so common. So hypertension, one of the risk factors for atrial fibrillation, most common is blood pressure. How can we have an instrument which will be less reliable?
Yes, sir.
So you should know about the studies of blood pressure measurement in atrial fibrillation. The
Yes, sir.
oscillometric methods have been there are some
Another
questions.
thing is
So go on, sir.
Another thing here is your diastolic blood pressure. So your upper limb diastolic BP and lower limb diastolic blood pressure are different. So
Yes,
actually it should not. So that is one of the most important thing. Your diastolic BP is 58 there and 50 there. So
Yes.
that should be equal, provided you are using an adequate cup size.
Yes.
Okay, go ahead.
Sir, on inspection, sir, chest is bilateral symmetrical without localized or generalized bulge or retraction, sir, or kyphoscoliosis, scoliosis. Apex impulse is situated in the left 6 intercostal space lateral to the mid-clavicular line, sir. Bilateral supraclavicular and suprasternal pulsations are present, sir. Bilateral dancing carotids are seen, sir. No other dilated veins, scars, or sinuses. Back and spines are normal, sir.
So what is the inference from these findings? So here you are getting a cardiomegaly, but the chest is bilaterally symmetrical. That means everything happened after the fusion of the costocartilage junction. So this cardiomegaly is of recent origin and it is not there since early childhood.
Yes,
if there
sir.
is a cardiomegaly from early childhood, you might get chest wall abnormalities and ectus excavatum and other things, because there is huge cardiomegaly on this because apex is situated in 6th intercostal space.
Yes, sir.
Okay.
Yes. So palpation, sir. Apex bit is at 6 intercostal space, 1.5 centimeter lateral to the mid-clavicular line, sir. It is localized, sir, hyperdynamic in nature, LV type of apex, sir. There is no systolic or diastolic thrill, sir. Grade 2 parasternal heave is there, sir.
Okay.
Sir, percussion, sir.
So what is the
border,
inference from this? What is the inference from this?
Sir, from here I can identify there is a predominantly volume overload features where there is a cardiomegaly and there is significant LV is dilated, sir. And uh, along with this, there is a severe pH also, sir.
There is a significant pulmonary hypertension.
Yes.
And there is no systolic and diastolic thrill.
No, sir.
So that means,
Sir. So it means there is no severe MR is not the patient, because in severe MR the patient will have the systolic thrill will be there, sir. And
okay, that means there is something which might be originating from additional wall like aortic wall.
yes, sir.
Okay. So what are the causes of diastolic thrill in aortic regurgitation?
Sorry, so if the AV dissociation is there or there is acute AR, sir.
So how AV dissociation produces aortic regurgitation thrill?
So because the LV will contract against the uh, uh, against the opened valve, so there will be patient will be having MR, sir. Because ideally, because with the
Then I am asking about the causes of thrill in aortic regurgitation.
thrill in aortic regurgitation. One if there is severe AR, sir.
You see so many severe AR, we don't get aortic thrill. So there are some specific causes of thrill in aortic regurgitation. One is that acute AR. So eversion or perforation of the cusp, that is the one cause which produces thrill in acute AR. Okay, next.
Sir, percussion, sir. Upper border of liver dullness corresponds to the right is the right fifth intercostal space. Right border of the heart corresponds to sternum. Left heart border corresponds to the apex. Left second intercostal space is dull, sir.
So what is the inference from this?
So from here, one is a situs solidus is there. Along with that, there is a dullness in the left second intercostal space. So there is a severe pH, sir.
There is no severe pH. There is a pulmonary artery dilatation.
Sir, there is a pulmonary artery dilatation.
If there is idiopathic dilatation of pulmonary artery, you will get a dull. Na?
Yes, sir,
So
there will be dullness.
pH will be after auscultation.
Yes, sir.
Then there is no significant RA enlargement.
Yes, sir, there is
and
no.
apex is correlating with the superficial dullness. That means there is no associated pericardial effusion.
Effusion, sir.
Okay, next.
Yeah. So auscultation, sir. S1 is variable intensity, sir. S2 is soft Soft A2 is there, loud P2, sir, with narrow split, sir. There is no S3, S4, opening snap or any added sound, sir. A grade 3/4, sir, long mid-diastolic murmur is there with pre-systolic accentuation, low pitch rumbling quality, sir. Best heard at the left lateral position at the end of expiration with the bell of stethoscope, sir. So another one murmur is that grade 3/4 murmur, high pitch, early diastolic murmur, lasting up to later 1/3 of the diastole, best heard at the left third and fourth intercostal space in sitting and leaning forward position at the end of expiration with the diaphragm of stethoscope. Sir.
What is the mechanism of this pre-systolic accentuation?
So it's the LA contraction leading to it's like sudden opening of the
In your patient,
AF is there.
So it can be because of the short cycles or patient because of the higher AV pressure gradient that leads to sudden opening of the valve and that leads to the pre-systolic accentuation can be there. Sir.
Here you have bradycardia, right?
Yes, sir.
You don't have fast rates. So long cycle, short cycle, what you're trying to say will not happen. But again, the question is, you can still get pre-systolic accentuation despite bradycardia in severe mitral stenosis with complete heart block with AFib. Now, what are you suspecting? So basically, what is the mechanism of a pre-systolic accentuation in patients who don't have LA contraction? This is one of the fallacy of
yes, sir. So it is a high AV pressure, high.
You can have, like, for example, let us be very clear. Can you have pre-systolic accentuation in AF or not?
Sir, in AF it is less likely until unless if the patient
you can have now. Like, what is the mechanism?
Yes. So in AF it is a mechanism is that if the patient is having short long cycle, in the short cycle because of the high pressure gradient, that pressure gradient will be because of that high pressure gradient there will be sudden opening of the valve and that leads to the pre-systolic accentuations.
Go on.
Right? So when a long cycle follows a short cycle, the previous short cycle has not allowed complete emptying of the LA and the LA gradient has already stayed there, right? Now when a long cycle follows, there is additional venous return from the next cycle, which will further accentuate a development of a pre-systolic accentuation. That is one. Can you get the other way around? When you have a long cycle, when you have a short cycle and another short cycle also follows, can you now have a pre-systolic accentuation?
Yes, sir. So again, there will be high transmittal gradient will be created because if the patient had a long cycle, there will be
pre-systolic accentuation before the LA contraction. What is happening in the ventricle?
Sir, during the long cycle, almost the blood has transmitted from the LA to the LV. So the LV has started getting accumulated, sir. And then when there is a short cycle, so there will be again.
So it's the same mechanism as what is being given as the mechanism of Austin Flint, the diastasis. The rising LV-EDP would further lead to back pressure changes into the LA, and the LA pressure, the gradient will actually diminish. But why still you would get a pre-systolic accentuation if that was to happen? So that would happen in an empty LV. Okay.
Yes, sir.
If the LV-EDPs are not still pretty high and the stenosis is severe enough, the LV-EDP will not rise as rapidly as it would if it was not to be a severe MS. So, in a short, following a short, also you can get a pre-systolic accentuation, but ideally they are best audible in this is the fallacy or one of the hypotheses, not a big series to document, but when a long cycle follows a short cycle, you can get a pre-systolic accentuation.
Yes.
Go on.
So there is also grade 3/6 medium pitch, sir, pansystolic murmur best heard at the apex in the left lateral position on expiration, sir. So other systems, sir, GIT, no tenderness, hepatomegaly or ascites, sir. CNS, there is no focal deficit, respiratory NAD, sir. So my final diagnosis will be, so it's a multivalvular heart disease. Likely rheumatic etiology in a form of severe AR and severe MS, sir. Moderate MR, sir. Severe PH, severe PVH in atrial fibrillation with controlled ventricular rate with no evidence of an infective endocarditis in congestive cardiac failure with NYHA class 2, sir.
Like how the patient becomes suddenly NHA class 2?
Sir, there was after admission, sir, that it's like after hospitalization when the patient was giving the drugs, that it's like that has lead to increase in the urination and then the patient was symptomatically better. So that's why.
Like, can you be absolutely certain about class 2 or class 3 in a hospitalized patient? Like,
Yes, sir, there is less because
no,
patient will
suppose
not.
he was class 4 one day before. Next day he becomes. Can he become class 2? Like, will you categorize him as class 2?
No, sir, sorry, sir, it will be NYJ class 3, sir. Because patient
So,
will not
Well,
be
you cannot.
mobilized, so we know this.
You cannot. You should ideally not comment, or you can mention currently is comfortable
See,
moving around to the urinal, etc.
Yes.
so in patients with severe aortic regurgitation, how you quantified the mitral regurgitation is moderate?
Sir, as the the patient.
My first question is how you quantified the aortic regurgitation as a severe? That is my first question. And in presence of severe aortic regurgitation, how you quantified the mitral regurgitation as a moderate?
So one severe AR, because as the patient is having long duration of murmur, sir, apical impulse is down and out, sir. Uh, uh,
hey, can that be down and out because of MR, or can that be down and out because of AR? Both of them are possible. So the first question is, how are you sure that this is severe MR or severe AR and moderate MR? Because both of them can produce LV apex, down and
yes,
out
sir.
apex.
Sir,
What is your Hill sign here? What is your Hill sign here?
So there is 40. The pressure difference between the upper and lower limb is 40, sir. So Hill sign goes more towards the severe AR, sir.
See, here
How
you
much
cannot
40
put a
will
Hill
quantify
sign
as?
because your diastolic blood pressures are not equal. If the diastolic BPs are not equal, then you cannot apply it for the Hill sign.
Yes, sir. There is a high pulse pressure, sir. So there is significant high pulse pressure that will be present in case of severe AR only, sir.
So what is the most important finding in your case that will say this is severe AR? Your Hill sign is not supporting you.
Sir, one wide pulse pressure, sir.
No, anything more than that? Because your blood pressure is not like a further wide. It's 140/60 or so.
Sir, pulses bispheric, sir.
Anything else which is a far more important one? What about the duration of the murmur?
Has a long duration of murmur, sir. It is
So
early diastolic.
that should be a first thing, like. So how much Hill sign do you anticipate in a patient with severe AR?
Sir, severe AR Hill sign can also be false negative, sir. If the patient is having severe.
No. What is the Hill sign you expect in a severe AR generally?
So there will be
More than?
the difference between the upper and lower limb. If the patient is having mild 20 to 40, moderate 40 to 60, and more than severe if it is more than 60, sir.
So you expect 60, more than 60. What are the situations in which a patient can have severe AR at the same time Hill sign is less than 60?
So if the patient is having severe LV dysfunction, sir, or any condition that has lead to raised LVDP, such as if the patient is having associated severe aortic stenosis or refractory hypertension, sir. So that has lead to raised LVDP. So there will be decrease in the pressure gradient between.
And acute AR.
Yes, sir.
So what about such question, like how do you assess MR severity in the presence of a severe AR? So you are absolutely certain that because of the the long murmur, you think that this is severe AR. But suppose, how do you assess in that presence? How do you assess the severity of MR?
So one in presence of severe AR, MR will be overdiagnosed because there will be excess volume of the fluid, sir. Along with that, sir,
is there excess volume across the mitral valve?
So how was your heave? And was it just systolic or a late systolic or early systolic?
Yes,
Was
sir.
it the
Yes,
LV
sir.
heave?
Actually, here it was like, sir, this paracenal heave was persisting throughout systole. So there was going more towards the paracenal heave second to the PH, sir. And in case of severe MR, sir, if the patient is having LA enlargement, the paracenal heave will be late systolic, sir. It will be only present during the late systolic, sir. And the
See,
explanation.
the only one thing which helps in your diagnosis of MR is associated atrial fibrillation. So atrial fibrillation is relatively more common in patients with MR,
Yes, sir.
and that is the only thing. Then another thing is that there is no opening step.
Yes, sir.
So these are the two things. Otherwise, everything is you cannot quantify the MR. So here you can say that there is a severe aortic regurgitation, and I am considering hemodynamically significant mitral regurgitation. It might be mild or it might be moderate.
Yes.
What is the one clinical finding that if it is there, then you can say this is severe MR? In a multivalent heart disease, if that finding is there, you can definitely say that, put your foot and say this has to be severe MR.
Sir,
What happens to split of second sound in severe MR?
shall be wide split, sir.
So if you find in such a scenario, if you find a really wide splitting,
Wide
wide
split.
mobile splitting of second sound, you should think of a severe MR. Apart
Severe
from that, there is no other sign which you can categorically say this is severe MR. There are only
Yes.
the circumstantial evidences that to suggest that this could be significant MR.
Yes.
And one more thing is always put your PVH before PH in terms of diagnosis, and include no evidence of rheumatic activity also in any acute worsening of heart failure.
Yes.
So
Splitting of second heart sound tell you about the etiology of MR? DCMP MR, MVP MR, HOCM MR. I've given you a clue. Now what happens to the splitting of second heart sound in all three? DCMP will have LBBB. So what will be the splitting?
So there will be narrow splitting will be there because
LBBB. LBBB will be paradoxical, right?
yes.
And LV dysfunction, so E2 gets delayed. What about HCM? Or rheumatic for that matter. Rheumatic usually, sir has already told you, know, what happens to splitting.
So there will be wide split.
Rheumatic MR. Yeah, wide split.
In rheumatic MR there will be
So, I
wide
mean,
split.
yes, so if you get LBBB, so likely to go with BCMP, right? I mean,
Yes.
that's LBBB in rheumatic MR is pretty unusual, very rare. But DCMP, LBBB is pretty more common. So sometimes splitting can tell you the etiology of MR
Okay, sir.
if you're dealing in MR.
What were the findings of severe MS in this?
Sir, in severe MR, one, the patient is having severe PH, sir. Along with that, patient is having pre-systolic accentuation, sir. So there are the only and there is a long duration of murmur, sir. Long mid-diastolic murmur with pre-systolic accentuation with severe PH, sir.
patient is in AF also, and then as well as patient is class 4, like orthopedic patient.
Yes,
Right?
sir. Patient is in class 4.
But which is dominant? Why are you saying that this is severe AR is dominant in this case?
Sir, here I'll keep it as a dominant lesion, severe AR only, because apex is shifted down and out, sir. And there is a wide pulse pressure. Hill sign is positive, so I'll try to keep it as a severe AR as a dominant lesion. And then,
What is the controversy about hill signs? So we have
I
talked so
think
much
all
about
the
hill signs.
symptoms. I think all the symptoms in this patient are related to the mitral valve disease.
Disease
yes,
only, yeah.
yes, sir. There is one thing that the patient symptoms are towards the severe MS, sir, but hemodynamics, sir, it is showing severe ARs also. Sir.
So that is why I had, even though your LV apex is AR, you should say AR as a dominant, but then sir is pointing out everything is because of MS only in this guy.
Yes.
So I think I would write the severe MS first, then severe AR.
You have to write a mitral valve disease first and then severe MS.
It's a marginal point. It's not a significant point, but that's a very important point for you to think, like, because that is what has brought him. Like, that is what has made him
If you
class 4.
keep a severe AR as the first thing, everything focus on the aortic valve only, and we might, for management point of view, we might do some wrong decision. Here we
Yes,
have
sir,
to
that's-
think about a mitral valve first.
Yes, sir, they're
So
absolutely
how
right,
will
sir.
you investigate this case?
So first we'll get a ECG, sir. Then we'll get a 2D echo, sir. And in the 2D echo we'll identify and then we'll see the lesion, sir. That if the patient is having severe MS and
How the ECG is going to help
sir, ECG
in
one
finding
thing,
out the
sir.
severity?
Sir, if the
Can you show the ECG?
yes, sir, I can show. Sir, this is a standard 12-lead ECG, sir. Suggestive of AF atrial fibrillation with fast ventricular rate with the patient is in right axis deviation, sir, or with the
Well,
axis
you
of
are
around.
presenting today. So today your heart rate is only 64 or 66.
Sir, this was on presentation, sir. Sorry.
So is a today's ECG is also there?
No, sir. Today's ECG is not there, sir. This was just on the presentation. I've got ECG and then.
Okay.
So this is a standard 12-lead ECG with the suggestive of atrial fibrillation with fast ventricular rate. There's a presence of fibrillative wave with the right axis deviation with the axis of around 120, sir. Suggestive of, sir, actually this helps that the patient is having right axis deviation. It is more likely the patient having severe mitral stenosis. This ECG goes towards severe MS, sir.
Can it be MR, not MS? With
So it
your
is.
clinical history.
Is there any evidence of left ventricular volume overload in the ECG?
Yes, sir, in V5, V6, there is presence of Q wave with upright T waves are there, sir. So both the features are there. The right axis deviation with LV volume overload features are there, sir. Sir, along with that, sir, this right axis deviation will be go more towards this mitral stenosis, sir.
Okay. So ECG wise, there is a evidence of mitral valve disease with some evidence of significant pulmonary hypertension, atrial fibrillation, fast ventricular rate, and
Yes.
some clues for LV volume overload.
Volume overload.
So the ECG more.
The only thing is that you are not getting a tall
mitral
R
valve
wave in
disease.
V1.
Yes, sir.
Only
Sir,
thing missing is that there is no tall R wave in V1.
Yes, sir. This it is not like categorizing the features of RVH, sir. In that there is no sufficient amount of tall RVs.
Why you think that is happening? Like, what is the explanation for that?
So one there is a
In other
patient.
words, in patients who have biventricular hypertrophy, so how common is to find features of RVH and features of LVH in the same patient, like?
So that Cat-Schwechel phenomena that.
So what are the other indicators to say how do you diagnose biventricular hypertrophy? How sensitive or specific is this as on ECG?
So that is on the Cat-Schwechel phenomena, so that there will be right ventricular hypertrophy. R wave in V1 will be more than 7, while in R wave in V5 plus.
So in which condition you find it? Like, will you ever find it in MS with AR? You don't commonly find that, na? Cat-Schwechel
No,
is
sir.
limited
No,
to
sir.
mostly found in which condition commonly?
VSD with Eisenmenger syndrome, so it is.
VSD with Eisenmenger.
No, sorry. Biventricular. It will be.
Why should Eisenmenger have an LV force?
No.
So it is found generally in high flowing VSDs, moderate or large VSD, which are very, very high flowing,
Large views.
where there is both
Yes, sir.
pH is there as well as large flow is there. So it's generally found in children like. So
Yes, sir.
what the explanation for that is generally, so both the hypertrophy are there. At times the ECG is not able to pick them up. The forces get cancelled out, and it's not
Yes.
common to find features of RVH and LVH in the same ECG. So as you correctly said, one of the important feature to look for is presence of LVH with right axis deviation. You should think of it.
Yes, sir.
So can you go on to X-ray, sir?
Yes, sir. So this is a chart. So this is chest X-ray AP view, sir. There is
See,
a
1 second. Here, there is evidence of RA enlargement, and on your percussion, you had not shown any RA enlargement. So there is one missing of this finding. Huh? There is significant RA enlargement.
Yes, sir. There is a significant.
There was elevation of JVP, also significant elevation. That also suggested significant right heart overload. There should have been RA
Yes.
enlargement on other examination findings also.
Yes.
So can this be LA? Like, can the
Sir?
whole thing be LA? How do you differentiate? Suppose very rarely in patients who have mitral stenosis and mitral regurgitation, lesion the right heart border can be formed by LA. So how do you differentiate that from this? Like whether it is RA or LA?
Sir.
So that shadow, if it's an LA, generally doesn't touch the diaphragm, like.
No, sir. That LA will not touch any time the diaphragm. It is just the RA.
So that is the differentiation. How do you differentiate from if it's a right heart border is being formed by LA or just getting pushed, like?
Yes.
So what else is there? What are the other findings are there?
So there is a cardiomegaly. There is significant LA enlargement. There is straightening of the left heart border. Is there double heart counter? Is there is significant RA enlargement with LV type of apex is there, sir.
And what about pulmonary venous hypertension, pulmonary arterial hypertension?
There is a moderate PVH, sir. There is syphilization of the veins, sir. There is dilatation of the upper pulmonary veins, sir. That, and along with that, there is a mild interstitial edema.
So maybe this was taken when he was really sick, I think, maybe.
Yes, sir. This was the first X-ray, sir, when the patient presented at that time, sir.
So you can actually read it like pulmonary edema, like. There are
Yes,
some
sir,
features such as pulmonary edema.
A good pulmonary edema.
And see some bad bronchogorams here.
Yes, sir.
Go on.
So these are echo, sir. So this is a parasternal long axis view, sir, with significant LA enlargement, sir. Mitral valve is rheumatic in nature. There is significant diastolic doming of the anterior leaflet, restriction of the posterior leaflet. There is a moderately calcified mitral valve. Along with that, even we can see here there is an aortic valve also is rheumatic in nature, and there is sufficient amount and there is significant amount of subvalvular pathology is there, sir.
Can change the loop.
Yes, I also.
To show all the.
So there is a color flow Doppler imaging of the same parasternal long axis view, where you can see here there is a moderate amount of MR, sir. There is a posterior directed jet we can see here, and along with that there is significant amount of AR, sir.
It's not focused, so we can see other view. Yeah, now you should.
Sir, this
we
one
can't see the proper echo findings in these views. We need better views.
So this is a view demonstrating a significant amount of AR, sir.
Can you show other views? Next slide.
Yes. So this was a mitral inflow gradient, sir. Here the pressure of time was taken in the mitral inflow. So the pressure of time was 1.23 seconds. Pressure of time is 179 milliseconds, and mitral area by PST was 1.23 milliseconds. So.
So again, like I think it's a good idea to always have an ECG when you're recording and showing in a for this kind of a purpose. And then secondly, in an atrial fibrillation, you're supposed to take not one and multiple things has to be shown. Like you
Yes,
cannot rely
minimum.
on one gradient like this.
Yes.
But here the patient seems to be in sinus rhythm.
And quite
Yes.
regular like this one seems to be quite regular.
Regular,
Yes.
and also you can see A wave very clearly here.
Yes. So this was after the patient was giving
Yeah,
diltiazem.
this is a sinus rhythm only because AVO
Yeah.
is absolutely clear. So this is not a AF.
Yes.
So right now the patient is in sinus rhythm.
Yes, the patient was reverted also with the diltiazem. So
And do you expect that to be reverted with diltiazem? When you use atrial fibrillation, as a cardiologist, will you think that the patient will come back to sinus rhythm with diltiazem?
so less likely, but
So it was spontaneous. The diltiazem may have
Yeah,
it just
you have to
controls
say
the
that
rate,
it's
right?
spontaneous. You try to control the rate, then it could have reversed with spontaneously. Like
yes.
so, what are the class of drug that will generally useful to revert sinus rhythm
Sir,
in atrial fibrillation? What are the drugs that are recommended to get the patient back to sinus rhythm?
in case of rheumatic heart disease or non, it's like non-valvular AF.
So both,
Then
yeah, if you can say in rheumatic heart disease, both it will be fantastic.
So in case of
What are the drugs
non-valvular AF,
recommended for converting a lone AF?
so in
And what is the
non-AF,
evidence for rheumatic heart disease?
so in non-valvular AF, sir, ebutalide is highly predictable, sir. It has got highest amount of success rate, that is around 78%. So that it can revert the AF to the sinus rhythm. So,
What else?
so ebutalide,
Peel in pocket.
sir, if the patient is having no structural heart disease, propofenone and flecainide can be given, sir. In
Which
absence of any
structural
structural
heart
heart disease,
disease? What do you use?
sir.
Which structural heart disease?
So in absence of any LV dysfunction, propofenone or flecainide can be given, sir.
In rheumatic heart disease, let me ask specifically.
Sir.
In rheumatic heart disease,
Yes, sir.
there is a trial called PROF trial, which was done in India, which has shown amiodarone to be superior. Rhythm control was better than rate control in rheumatic heart disease.
Yes.
Dr. Mahajan's Institute only, I think the paper was from KEM.
Yes, absolutely. So provided LA size is not more than 55. So most of the time, if LA is less than 55, the chances of getting back to the sinus rhythm are very high. That too with the amiodarone.
Yes.
So here your ECG suggestive your patient had gone back to the sinus rhythm
Yes.
with the medical management. So people might have used amiodarone in this case. LA is not that much huge. X-ray wise it was too huge, but here it is not that much huge. Let's go to the next view. Next loop.
Video is not playing. How?
So there is a apical 5-chamber view which suggests of significant amount of regurgitation is there from the aortic wall rheumatic in etiology, and followed by which the half type was taken. So this was the pressure half time. So there is a AR PST was 123, the suggestion of severe AR. So
Okay.
see, I think this PHT measurement is not correct. We can't see the clear downslope. But if you go back to the previous slide, LV doesn't appear to be that enlarged before this. No, previous slide. Yeah. If you look at the LV on top,
yes, sir.
there doesn't seem to be LV enlargement there.
Yes.
And ARZ is also not that impressive.
Yes.
It appears more like predominant severe MS.
Go on.
Next.
Sir, that's it, sir. I was done, sir.
What about planimetry of mitral valve? So you ended up with a 1 point, any TR velocity you got?
So mitral valve area by planimetry was a 1.2 centimeter. It was as well.
No, how can it be 1.2 centimeter? The patient is so sick and
So you have to show us the planimetry of mitral valve and all parameters which can judge regarding transcatheter management of mitral valve, like a balloon mitral valvuloplasty. You have to find out is patient suitable for that. Then what is happening to the tricuspid valve, that also you have to show it. And what is the forward gradient of aortic valve here, that is very important. Because if there is a significant forward gradient in aortic valve and if you are attempting a balloon mitral valvuloplasty, then you have to be very careful because you have to keep the surgeon standby very active.
what do you want to do for this patient? Like,
Sir?
what do you want to do for
How
this
will you
patient
manage
now?
this case?
So this I'll go for the double valve replacement, so MVR plus AVR. So
No, why no other option is available? Why you want to do the change both the valves?
So I already told patient balloon valvuloplasty will be better option because he is just 25 years old.
What is the problem with BMV in this patient? Like, what are the issues?
So one, the valve is significantly heavily calcified, along with the patient is having moderate MR, sir. So that goes that we cannot perform a BMV in this, sir.
So you are not shown us the short axis, you are not shown us the planimetry. So how can we decide the balloon valvuloplasty just with the clips which you are shown? Your echo assessment is not complete to decide regarding the management of this case.
Do you have any other view?
So these are the only views of that.
The planimetry was not done.
So actually,
Dr. Bansal actually elucidated it very well. Anatomical assessment versus in a multivalvular.
See, in this pressure half time gave you mitral valve area 1.2, which appears to be fallacious. Mitral valve area is likely to be much less, and this discrepancy is because of increased LVDP due to AR, aortic valve disease. So planimetry would be much more useful here.
yes, sir. Yes, sir.
So maybe like this is dated yesterday afternoon. So when did you examine the patient? When is he now? Is he again gone back to atrial fibrillation now?
Sir, yesterday I've seen that. Today again I have not seen that patient, sir, again.
No, yesterday evening. This is sinus rhythm. Yesterday evening.
Yes, sir.
This is dated 9th 4:30 p.m.
Sir,
So
actually,
the bradycardia was sinus rhythm.
has yes, sir. In the it was in the sinus rhythm when the echo was done, sir.
So how will you manage this case medically?
So clinically, sir, there's a
So you have to do definitively you have to do something for that valvular involvement, so that that decision will come with only proper echo only. But prior to that, how to manage this case medically? So how you are managing this medically? Because the patient is coming in sinus rhythm, now looks better, ventricular rate is controlled. So what you had done is absolutely right. So what Dr. Kamal Sharma sir had told you to manage this case, so you just tell us the same thing.
Sir, we have decongested, sir. So we have given the Lasix, and along with that, we have given the rate controlling drugs, sir. So it's like to control the atrial fibrillation, sir.
So which rate controlling drug you had given, and is there is any role of anticoagulation in this case prior to bringing him back to the sinus rhythm?
Yes, sir. We start with the anticoagulants, sir. If the patient is having RSD and the patient is having RSD and the patient has come with AF, so you start with the heparin, sir. That we have started with the anticoagulation, sir.
Can you start him on Novax or you want to put him on OSCs?
So oral anticoagulants.
Why not Novax?
Sir, NOAX till now, sir, there is no data, sir. It's like proved to be, it's like beneficial in case of rheumatic heart disease.
There is no
The,
data.
but
Rheumatic mitral stenosis.
the largest trial was that has tried with the rivaroxaban, sir, and that was proved to be harmful rather than beneficial, sir, in case of valvular heart disease, in case of rheumatic heart disease.
Anyway, this patient is scheduled for surgery, so you'll have to probably keep him on heparin. So now he has converted back to sinus rhythm. So will you still put him on heparin while he is waiting for surgery?
So we'll continue the heparins at least 6 hours before the surgery, and then afterwards we can.
No, now he is in sinus rhythm. Why you want to give heparin?
So if the patient, so in case of, so if the patient is having significant rheumatic heart disease with severe mitral stenosis, so in case of valvular heart disease, the patient is present to us.
So intermittent AF, paroxysmal AF, you will anyway continue with the heparin. No? That's what your answer should be. So if it's a paroxysmal AF, even if it converts back to normal sinus rhythm, the structural defect is there. You will continue with heparin till the time he goes for surgery.
Yes.
And also, you see, in AF, the chances of clot formation are more after cardioversion rather than before because of atrial stenting. So continuation of anticoagulation for at least
there is
3.
any role of LA osteal velocity? If it is more than 0.5, then one may think of going off anticoagulation. But if left atrial appendage osteal velocity less than 0.5 meter, then you have to continue with the anticoagulation. Am I right?
Yes.
Is there any role of penicillin prophylaxis in this case?
Yes, sir. And we have to continue the secondary, like we have to continue the secondary penicillin prophylaxis in this patient. Even the patient goes to the surgery, still we have to give, sir. And this should be given at least for like till the 40 years of age, or it can be also given lifelong, sir.
Okay.
In this patient, there was significant RA enlargement, JVP was elevated. So this patient had significant tricuspid regurgitation also.
Yes, sir.
So as I was mentioning, we should not think about tricuspid regurgitation also in this while managing this patient. So just DVR may not be sufficient if there is significant TR.
Yes, a TV repair should be given if the patient is having, we are going for the double valve replacement, and if the patient is having severe TR, severe PH, ideally the patient should undergo TV repair also.
Okay, thank you, Dr. Devrat. It is very nice presentation. Only you have to improve as far as the echo is concerned, because in this case your echo examination was not up to the mark. You have to find out the anatomical suitability of mitral wall. Is there is any is the balloon burst is visible? Then is there is any forward gradient across aortic wall? And quantification of tricuspid wall. Sometimes one may get associated of pulmonary wall involvement also. So that you have to be very careful.
Yes.
That is the thing which I just want to mention here. Otherwise, your presentation was excellent.
Thank you, sir.
Very well done, Devrat. It's a lot of courage to present among so many people. So very well done.
Thanks.
Sir, thank you, sir. I think Dr. Devrat did a wonderful job. Nicely sailed through all the choppy waters. Barrel of questions you have really asked. Nicely handled. And I'd also like to thanks to all our eminent faculty, Dr. Kamal Sharma, Dr. Ajay Mahajan, sir, Dr. Ramakrishnan, sir, as well as Dr. Manishwan, sir, for giving very critical insight on this valvular heart disease. I'm sure the students, those who are listening to this program, they will be really assisted this kind of insights and also helpful their academic or examinations as well. So I request all the PG students kindly, encourage more other friends also to participate as much as possible. and take this benefit of all these eminent faculties inside and case verification. And there's a small announcement from Macleods side that the top 3 case presenter students will be awarded from Macleods after the end of this 8 series program. So thanks once again to all our faculty and our audience for patience hearing. Thank you, sir. I request Dr. Mahajan sir and Kamal sir give you, last address. Any message for the audience, sir? Please.
I must thank Dr. Ramakrishnan for accepting this at the last moment. He agreed to join in. Thank you very much, Dr. Ramakrishnan. Also, Dr. Bansal. It was wonderful to listen to you. Not only students must have learned, but it was insightful, even revising and learning new things from you, from your presentation as well. And of course, Dr. Mahajan, thank you very much for mentoring the whole program. Thank you to Macleods and Dr. Devra for presenting the case. Thank you, everyone. Dr. Mahajan?
Sorry, some questions are there unanswered. So if you mind, sir, just take on some questions. Dr. Mahajan,
Can
sir,
you read the questions? So we can.
Yeah. One question, Dr. Subhash is there from Kolkata. He is asking, regurgitations will have rapid progression, stenosis slow progression.
I think many of them have been answered, sir. I think many of them have been the discussion that when we were asking, they were type the things like.
And one
So
question.
it's all about the kind of comments when we are discussing. I think nothing much is there.
Fine. Thank you, sir.
Thank you, everyone.
Thank you all, sir.
Thank you, Dr. Ahmad.
Thank you.
Thank you, Dr. Bansal. Thank you, Mr. Kanu.
Thank you, sir.
Because
Thank
of you only this new initiative started since last 3 years. So hats off to you.
Thank you, sir.
Thank you,
sir.
All students will get a benefit.
Yes.
Thank you.
Thank you, sir.
Thank you.
sir.
Good
Meet
night.
after 50 days.
Sir, good night, sir. Namaskar, sir.
And all the best to Devdutt.
Yes.
Thank you, sir.
Thank you, sir.
Okay.
Thank you.